accepting our abstract for our presentation. The slides are here. Okay. Chronic hepatitis delta presents a more rapid disease progression than chronic hepatitis B. In fact, those with chronic hepatitis delta will have between 2 and 3 times more risk of developing liver cirrhosis, between 3 and 6 times more risk of developing hepatocellular carcinoma, and double the risk of undergoing liver transplantation, having an hepatic decompensation, or liver-related death. Chronic hepatitis delta is the fastest progressing form of viral hepatitis known, and it is often diagnosed in advanced stages of fibrosis or even cirrhosis. European, Asian, and WHO guidelines recommend anti-delta testing in all surface antigen positive individuals. And in contrast, American guidelines still recommend anti-delta testing in surface antigen positive people with risk factors. Nevertheless, the screening consists of the determination of anti-HDV antibodies and, if positive, determination of HDV RNA, if possible, quantitative. Various studies show that despite the guidelines, the implementation of these guidelines is still low. In our hospital, in Vall d'Hebron University Hospital here in Barcelona, we wanted to check how many anti-deltas were being requested over the total surface antigen positive samples, and we were really surprised to see that only 7.6% of anti-delta were being requested. And from then on, we decided to implement reflex testing, which consists of each surface antigen positive sample will be automatically tested for anti-delta. And we were, the results show that after the reflex testing implementation, the absolute diagnosis of chronic hepatitis delta were quintuplet. And in addition, 60% of anti-delta positive patients did not report any risk factors, in contrast with the American guidelines recommendation. I would like to present the OPTI-EBD program, which is an implementation of adult opportunistic screening and linkage to care in Catalonia, Spain. The primary aim is to implement anti-delta reflex testing on all surface antigen positive samples from the 7 laboratories of the Catalan Institute of Health, which encompass the respective 7 tertiary hospitals, a high number of primary care centers, addiction centers, and prisons. As secondary aims, we wanted to create a registry of patients with hepatitis delta, to centralize the quantification of HDV RNA, to use the same technique in all cases, and to link those patients who are not already in the care system. This is a study design. It's comprised in 3 main blocks. First, the laboratories receive all the surface antigen samples and will perform anti-delta on them. And if positive, HDV RNA quantification will be performed in a central lab. Clinicians will then be in charge of reviewing clinical records and link to care those patients who are not already, and will also be in charge of prescribing treatment if needed. And pharmacy department will be in charge of treatment dispensation and adherence monitoring. And just to highlight the figure of a study coordinator that ensured that all the steps were being followed in these 3 blocks. These are the results from January 2024 till March 2025. Over the course of these 15 months, we were able to screen more than 6,000 anti-deltas. And interestingly, 47% of these anti-delta determinations were requested for the first time. After deleting the duplicates, we identified 215 anti-delta positive patients, 68 of them being viremic. And this is our cohort. The median age of the patients was 55. Majority of them were male, Caucasian, and with no risk factors reported. And when comparing those viremic and those non-viremic, we could see that viremic patients were more often Caucasian, and especially from Eastern Europe. Continuing with the comparison, we could see that also viremic patients were had more frequently elevated ALT levels, were more cirrhotic with higher liver elastography values, and were more often treated with NUC and had more often received pegylated interferon. From the total viremic patients, we were able to link to care 64 of them, and 29 of them are currently being treated with bulevirtide as the main, as as the main gold standard treatment nowadays. We wanted to see what was the differences between those treated and non-treated within the viremic group, and we could see that those treated had more often elevated ALTs, were more cirrhotic, and had experienced more failure to pegylated interferon. We wanted to go a bit further, and we wanted to see those not treated, why they were not being treated. The main reason was a still pending evaluation. The second main reason was the non-reimbursement. In Catalonia, we had a patient prioritization for the treatment, so these patients are still under re-evaluation. Then we had some loss to follow-ups, some contraindications, and other reasons such as low expected adherence to treatment. To conclude, this active diagnostic program has allowed the testing of anti-delta for the first time in 47% of surface antigen-positive samples, identifying 68 cases of active hepatitis delta in 15 months. The majority of viremic patients were men from Eastern Europe with elevated ALT values and liver cirrhosis. Almost half of the patients with active hepatitis delta infection are receiving treatment with buleverside, particularly those with liver cirrhosis and previous pegylated interferon failure. And lastly, integrated hepatitis delta programs are essential for optimal diagnosis and disease control. And lastly, I would like to thank all the collaborators of this project, and thank you very much for your attention.